this one, this class is going to be pretty full on. Okay, it's going to be full stick. We'll come back to those questions, or we'll probably tackle those questions in the tutorial. I feel that'll be a better thing. So guys, what are we doing here today? We're going to be looking at some gas laws. However, I'm going to be super brief. There's only one that I really want you to properly focus on, and that's one that we covered in the tute last week, which you all did very well on, and that was Boyle's law. Okay, who can tell me what Boyle's law is? Just nice and simple. Anyone have any idea? I want you to type that in there for me. Just a very simple explanation. How would you do that? P1V1 equals P2V2. Exactly. So it's a negative correlation. So what that means is, as say volume as volume goes down, pressure will go up. So they are inverse. Excellent, good. We're going to be looking at some lung volumes and capacities. We're going to be looking at the composition of air. We're going to be quite brief with that. We're going to be looking at O2 and CO2 movement around the body. We're going to be looking at ventilation and breathing. And that'll pretty much be it. Now, as I said to you guys last week, when we're looking at ventilation versus respiration, these are very different things. Excuse me. Okay, pulmonary ventilation is the process of basically moving air, okay? Moving air into the lungs, moving air out of the lungs. So remember, all the way from nose/mouth, all the way, okay, down the pharynx, larynx, and then trachea, bronchioles, okay, all the way down to the terminal bronchioles. That is where we are looking at the conduction zone, okay? This is where our ventilation occurs. And this is where you will see I constantly use the language air, okay? Because it's a combination of oxygen and CO2. Now, when we move past there, that's when we are in the respiratory zone. Now, the biggest thing that allows us to move air into our lungs and out of our lungs again is essentially pressure, okay? Pressure will move down its gradient. Now, when I say gradient, actually, let me do this. Here we go. Okay, if it's moving down its gradient like this, okay, so we've got a graph. It's going from high down to low, okay? That's its pressure gradient. And that is what we try to exploit with our lungs here. Now, just a couple of different values that you're going to see. You guys as future nurses will predominantly see this one. You will be working in millimeters of mercury, which, again, we've already been using that as a unit of measurement, okay? You've seen that in blood pressure, okay? So when we're looking at BP, that has been... that's when we've been looking at it for that, but chemists can also use atmospheres and torr. Don't worry too much about that. I just wanted to sort of point out to you guys that we do have several units for the same thing, which is essentially pressure. Now, of course, these aren't the only three. We have plenty more, but I digress. Now, this is just another really good diagram, really good schematic here of Boyle's law, and how this is sort of being represented is sort of like a piston, like you would see in your car. Now, how I want you to picture this is, imagine this container here is your lungs, and this big plunger, that is essentially your diaphragm. Now, what is happening here is that if I'm taking a big, nice, deep breath in, so nice, big, deep breath in, filling up my lungs, what am I doing there? My diaphragm is pulling down. And as my diaphragm is pulling down, that's like what this thing is doing, it is increasing the area of my lungs. And by increasing that area, it's decreasing the pressure. Okay, that's what we're seeing here. Pen. So as I tried to get my pen to work and it just was giving me issues, so I'm going to have to just slum it with my mouse, I'm afraid. So as we have an increase in volume, oh Jesus, that's awful, we are going to see a decrease in pressure. And as pressure will move down its concentration gradient, by decreasing the pressure, we are making sure that air is moving from high pressure to low pressure, which is moving into our lungs. That is how we breathe. Is that making sense, everyone? Again, I really cannot stress this enough. It's the same with our person-to-person lectures. Okay, please interrupt me. Please, let me know. Okay, if things don't make sense, or if you need me to explain something again. Yep. Oh, cool. Nice. Let me quickly... Cool. I just realized I hadn't checked my emails quickly in case people are having issues. Awesome. Cheers, guys. Nice. So, what am I saying here? What am I explaining and talking about here? Essentially, when we are breathing, especially when we are looking at forceful breathing, so forceful inhalation and forceful exhalation, we are seeing large changes to our ribs, okay? The rib cage will move up anteriorly and superiorly, so it's going to move upwards and it's going to move outwards and it's going to expand, okay? Because we want to pull those lungs open, really increase that volume, okay? So we can get heaps of air in. So big, deep breath in. Okay, and again, please remember Boyle's law. Okay, super important. We need to know Boyle's law. Am I going to get you to do a calculation using Boyle's law where I give you, specific volumes and changes in pressure? No, absolutely not. If you were doing, say, introductory chemistry, yeah, sure, definitely. But you guys aren't, so no. Do you need to know what Boyle's law is telling you, as in this inverse relationship? Yes, that is absolutely what I'll be getting you to know and to understand and to reproduce. Now, these are our respiratory muscles, which again we did in class last week. Now, I think it was Gemma from memory who said abdominal muscles, but again, we need sort of some more specifics here. When we are looking at inhalation, so breathing in. Now again, this is forced inhalation. Let me move myself around here. So with forced inhalation, this is where we see our sternocleidomastoid, the scalenes, pectoralis minor, pectoralis major for a minor bit, and of course our external intercostals. Okay, all of these muscles are going to be working together for the purpose of lifting the ribs up, lifting the ribs out, and really expanding that volume. Let me just get this working. Okay. Now, what we see here with our abdominal muscles is the ability for us to push the diaphragm up. Now, what do we accomplish there by pushing the diaphragm up? And that is to compress the lungs. Because what we are essentially doing is the opposite of forceful inhalation. Okay? Sorry, I just got that working now. Good. So with our forceful inhalation, how our goal was to stretch the ribs open, okay, out and up, okay, really expand that volume. By tensing our abdominal muscles, we want to push that diaphragm back up because we want to really compress the lungs, okay? We want them to shrink back in so we can exhale. Do we need to know this? Absolutely, okay? We need to know these. A lot of these should be a revision from A&P 1, but that might have been a little while ago, so definitely scratch up on these couple of muscles here, definitely. Sorry, one last thing too I forgot to mention, guys, is that when you are passively or quiet expiration, so what you guys are essentially doing right now, that does not use any of these muscles, okay? It is passive. What that means is that it uses two things, which again, we covered in the tute last week. two things. One, the elasticity of your lungs. So if you blow up a balloon and let it go, it will deflate by itself. The second thing it relies upon is that surface tension, okay? The surface tension inside of the lungs. And what that will do is help to sort of pull the lungs back in and help you breathe outwards. What am I saying here? Okay, this is pretty much everything I was just saying before. So when we're doing quiet inspiration, so which again you all are basically doing right now, unless you're listening to me while going for a jog or something like that, what's going to happen is in quiet inspiration, your diaphragm is going to constrict, okay? It's going to pull down. We're going to see some minor movements from the intercostal muscles, which is going to cause this expansion of the lungs, and you breathe in. Now, during our expiration, what's going to happen is that elastic recoil is going to pull in. We're going to see that surface tension within the alveoli, okay? This is something that surfactant helps to decrease, but we don't want to get rid of all of it. That's important, okay? We still need a little bit of this because it helps us to exhale. So, lung compliance. What is lung compliance? Okay, it is essentially how stretchy and durable your lungs are. Okay, this is a measure of our ability for our lungs to expand out and to get air in. This is why people who have emphysema, okay, they have a lot of difficulty breathing, primarily because their lungs are not very stretchy anymore. Sorry, I need to keep remembering to move my little webcam thing so I'm not sort of blocking the screen for everyone. So, lung compliance, or the ability for our lungs to properly stretch and recoil for movement of air, relies on two primary factors. The first one, tissue and cell wall stretch. So this again kind of makes sense, okay? If we want our lungs to expand and to get air in, they need to stretch. Okay, if we don't have our lung tissue able to stretch and expand, it's going to make it bloody hard to get some air in there. Now, looking at surface tension as well, okay, this obviously opposes that the expansion of the lung, and it helps to collapse them in. So too much or not enough surface tension can obviously cause issues in terms of our lung compliance. So labored breathing, or this is using our forced inspiration and forced expiration. I'm not going to go through all of this again. I've already done that when we were talking about the muscles used over here, okay? So that process that I was explaining where, you know, the muscles will constrict and it will expand the lungs and blah, blah, blah. That's what I'm explaining sort of here. Okay, interpleural pressure. Now, again, we touched on this a little bit last week. I've got to stop saying that. What this does is that it helps to essentially glue your lungs into your chest so that when your rib cage expands up and out, it will pull your lungs up and out as well. So if you have, say, a pneumothorax or looking at sort of a collapsed lung, what that means is that the lung is no longer attached nicely to that sort of thoracic wall, which means as I take a big deep breath in, okay, and expand my rib cage out and up, the lungs it's not going to follow along, okay, because it's not attached to it anymore. It's disconnected, which means nice big deep breath, nothing happens, okay, which is obviously, well, terrifying. So yeah, that's what we see there with pneumothorax. Okay, so let's talk a little bit now about airway resistance. So we've spoken a little bit about, looking at conduction and looking at movement through various vessels when we were looking at our blood flow, looking at blood pressure and stuff like that. Now, what we noticed there is that with our heart, when we were looking at, say, stroke volume and looking at, the Frank-Starling law and looking at some of the things that control stroke volume, okay, we looked at sort of different factors that can affect blood flow. So one big thing that we discussed there in terms of blood flow and looking at pressure and peripheral resistance was the changing of the diameter of our blood vessels. Now, that same theory that we covered when we were looking at our blood vessels, okay? Looking at vasodilation, looking at vasoconstriction, and what the effect is of vasoconstriction and vasodilation with respect to blood flow, we see the same thing with your lungs. So instead of vasoconstriction or vasodilation, we see bronchoconstriction and bronchodilation. Okay, they mean the same thing, except instead of a blood vessel, it's your bronchioles. I thought I heard something, which is terrifying because I'm home alone right now. Anyway, now, usually is kind of a key word here. It is usually insignificant because we have really big, large airways up at the top here, looking at your trachea and your primary bronchioles. And these don't have the ability to sort of constrict and dilate because they're surrounded by that cartilage there to sort of reinforce it. However, as we branch down lower and lower and they get smaller and smaller and smaller and smaller, this is where we see a lot more of that smooth muscle there that can constrict and dilate out. Now, this here is essentially where the saying like many hands make light work comes into play. There are lots and lots and lots and lots of these tiny little bronchioles. Do they, as an individual, have much of an effect in terms of the overall airflow into your lungs? No. You could have one of them just shut and you wouldn't even notice. But the problem is that there are a lot of them. So if a lot of them start to play up, if a lot of them aren't doing what they're told, that's where we get into trouble. So, airway resistance, okay, it is increased by bronchoconstriction. Now, this is not always a bad thing, okay? You guys are undergoing some bronchoconstriction right now. You are not using 100% of your lung tissue. Why? There's no point. You don't need it right now. Well, one would hope not, because if you are using 100% of your lungs to like that while you're sitting here enjoying this captivating and engaging lecture, something's probably wrong. Now, when that is happening far too much and you start getting shortness of breath and you're unable to really get air in, then we're in trouble. We see this in a couple of different ways. The first one, where it's sort of very severe, depending on the person, is asthma, okay? This is where we have uncontrolled bronchoconstriction, and basically they're really struggling to get air in. They sort of get that horrible labored wheezing, and they're having to then really rely on that active respiration to just, Jesus, get air into me right now, because they can't breathe. Now, another factor too with this, not only is looking at our bronchoconstriction, it is mucus, okay? And I'm sure we've all experienced this when you've had a horrible chest infection, okay? Sort of gets really clogged up with mucus and you just feel really weighed down in the chest, and it's just, you just feel really, it's just harder to breathe. Okay, because you're just so clogged up with mucus, and that's sort of like when we were talking about like blood viscosity. Obviously, it's not the exact same thing, but it's a similar principle there. It's sort of that thickening and clogging up of those airways, and it makes it harder to sort of get air in. Now, looking back at, say, asthma, you know, we've got the person there, they're having a severe asthma attack. They can't breathe. What do? They get their Ventolin, they get their puffer. They take a big puff. What that does is it causes those bronchioles to dilate, and then, okay, they're starting to get that bronchodilation, okay, the airway resistance, okay, the difficulty in terms of moving that air, it's going down, and okay, they can kind of breathe again, and they sort of stop panicking and all of that. Does that make sense, everyone? Is everyone's all good with that? Yeah. Give us that sweet okay emoji for all good. Cheering. I love it. Fantastic. I've already We've spoken about that. Okay, here we go. I want to talk a little bit about surfactant. So, what we have here is a water molecule. So oxygen here is negatively charged, and we have our hydrogens here that are positively charged. Now, when I'm talking about all of this like attraction and repulsion and stuff like that, I want you to literally picture magnets, okay? Like you have a positive and a negative, they attract, okay? If you get, say, a positive and you try and push them together, they're going to repel. Now, when we're looking at surface tension, what we see here with our water molecules is that this oxygen down here is negative. These hydrogens over here with this other water molecule is positive. Negative, positive, they will attract. So that is what we're looking at here with surface tension. So how does surfactant break that, or how does it lower that surface tension? How I want you guys to think about it, which is kind of weird, but whatever, let's roll with it. Let's say you are walking down the street holding hands with a loved one, okay? So you're walking down there, you're holding hands and you're being all cute and adorable and blah. Then suddenly your best friend sees this and they go, no, we cannot allow them to have this nice romantic moment. And your best friend basically jumps in between you and goes, no, you're not holding hands. Not while I am the third wheel of your relationship and we're having fun together, okay? And essentially will wedge themselves in between it and stop you two lovebirds from holding hands. That's kind of what we see here in a weird way. So what we have here is lovebird number one. Yeah, let me do this. So we have lovebird number one, and oh my god, lovebird with severe cardiac deformities there, number two, and then this here is the best friend that's getting in between it, and that best friend is your surfactant. Okay, by interrupting that sort of attraction there between the two water molecules, what that does is it lowers that surface tension because there are less bonds that can hold them together. Does that make sense, everyone? All right, what we'll do is hang on, let me do this. Okay, that's good. We'll go through we'll go through the next few slides, just looking at our overall lung volume. Then we'll have a quick sort of 5-minute breather. So, what we have here is our lung volumes and lung capacities. So, with what we were looking at here, imagine we are sort of zoomed right in. So we're seeing like water molecules. We're seeing H2O here, water molecules. Now we're zooming right back out. We are zooming out to looking at the lungs overall, okay? Because as I said, you know, like you've got your passive breathing in, you've got your forced inhalation, all this sort of stuff. Now we're going to be talking about those specific volumes and those specific capacities there. Now, this lovely, wonderful graph, we need to know it, okay? Gotta know it, gotta love it, gotta work with it. Because you guys as nurses are going to be working with this sort of stuff a lot. So, here, MV, okay, is short for minute ventilation, okay? And essentially describes the amount of air that we're going to be moving per minute. So, the big one here is tidal volume. Tidal volume is essentially what you guys are using right now. What this is just your regular passive breath in, regular passive breath out. So regular in, regular out. Just normal breathing that you do every day right now. That is our tidal volume. So what we're seeing here is like normal in, normal out. Normal in. Man, we should do some like meditation stuff. This would be sweet, okay? In, out. So you'll see there was a massive jump, and it was here, okay, this spike here, that I jumped from passive breathing, my passive inhalation, to big forced inhalation, really. And you saw a little bit, my posture changed quite suddenly when I did that. Okay, so my normal sort of breathing, you know, my shoulders are sort of just sitting there, slumping down as per normal with my poor posture. And then suddenly, and you'll notice like my shoulders and that were pulled up and back, my rib cage went up, yeah, really expanding that volume. And that's what we are seeing here, this massive inspiration, okay? And when we take into account the total of my passive breathing and that massive inhalation, that is looking at our inspiratory capacity. What does that mean? That is the maximum amount that I can inhale at one time. Now, our inspiratory reserve volume, that's basically how much you have left in the tank. So you'll notice that I can do, say, a normal breath in. So just what I did then, this is really hard to do online. So just a regular normal breath in, so breathing in, and then, so you can sort of do a passive breath in and then do a really big inhale on top of that without exhaling. So that normal breath in is the sort of top of your tidal volume. And then the big launching deep breath, okay, that is looking at your inspiratory reserve volume, okay? Now, I then exhaled normally, then again, breathing in, breathing out, then let's say, you know, I'm breathing in, breathing out, and then, and again, you'll notice my posture change the opposite. I'm slumping in, I'm compressing that thoracic cavity, I'm really squeezing my lungs in to try and push out a lot of that air, okay? So once I do that, I breathe out as much as I can, okay? All the air is out and it's done. I can't breathe out anymore. That is down here. I need to breathe. Jesus. Okay, that is looking at our expiratory reserve volume, because this is the maximum amount that I can breathe outwards. However, that does not mean that my lungs are, quote, empty. They absolutely are not. There is still air in the lungs. This is our residual volume, okay? This is our sort of the remaining residue of air that is still in our lungs that we cannot breathe out. And for good reason, because if we breathed out all of the air possible, we basically wouldn't be able to breathe back in again, okay? Because it would sort of form a suction, would sort of glue itself together. We wouldn't be able to open it back up again. So, we've looked at this inspiratory capacity, okay, this inspiratory reserve volume. So that's essentially the amount of air that you can breathe in after you've done a normal breath in. So you've done your normal breath in, then massive deep breath. Your expiratory reserve volume, that's when you've done a normal, just sort of normal breath out, and then you force the rest of that air out. Then our functional residual capacity, this is how much air you have in your lungs before taking a breath in, okay? This is how much you can forcefully breathe out of your mouth and how much air you've got left over in your lungs. Now, we look at our vital capacity, VC, okay? Vital capacity is essentially how much control you have over your lungs, essentially. So for me, a vital capacity would be, so that was me doing a forceful breath in. So whoop, going all the way up here, and then forceful breath out, and basically dumping my guts, you know, breathing out as much air as I can, right down to here. That is our vital capacity, because that is how much air I can totally breathe in and breathe out. The total lung capacity, TLC, that is looking at the full volume of air in my lungs total, including this lung capacity. Now, what we see here on this wonderful, lovely page here is looking at our respiratory volumes and looking at our respiratory capacities. So, you know, we're looking at our tidal volume, inspiratory reserve volume, all of that. So that's what we were looking over here. And then the total capacities, like total lung capacity, vital capacity. Ooh, excuse me. That's what we were seeing over here. Like, you know, inspiratory capacity, total lung capacity, blah, blah, blah. What do I expect you to know with this page here? Because obviously there is a lot of information here. Two things I want to mention here. One, these descriptions is pretty much what I was verbally saying on this graph. So what you guys should be able to do is not only be able to draw and label this, but draw and label this whilst doing this, okay? Explaining to me what each of these things mean. What is this squiggle telling me? The next thing I want you to know is obviously these measurements, these various volumes and capacities, which again is what we're seeing on this graph. Now, in terms of the our average volumes, there is only one I want you to know, and that is tidal volume. Okay, on average, it is around 500 mil. That's it. I don't want you to really learn the rest of these. I'm not overly interested. The reason is that it varies so much from person to person. Okay, so just as a sort of a bit of an example here. So looking at this graph, okay, looking at this sort of vital capacity, it's saying it's around 5 liters. Mine is close to sort of 10 and a half liters. Yeah, I've got a solid set of lungs. So it's different from person to person, and it will vary enormously. Say, if you were to compare my lung volume and my lung capacity to, say, Trish's lung volume and lung capacity, there's going to be there's going to be a large difference there. Why? Well, you compare the size of Trish and you compare the size of me, there's a large difference, okay? I am a bigger human being, so I have bigger lungs, and as such, this graph will change. It will be different for me, especially in terms of our lung volume. So please just keep that in mind, guys. Again, this slide here is just a good breakdown in terms of the measurements and the descriptions, and I would only expect you in terms of volume, here, to know, just know tidal volume. So how are we feeling, guys? How are we going? Because again, that was quite a lot of information I just threw at you guys all at once. Does anyone have any questions with what I've just covered over the past few slides? We're all good. Everyone's happy. So inspiratory reserve is breath forcefully. So the inspiratory reserve volume here, yes, that is essentially like when you've done a normal breath in. Okay, just to break down your question. So is your inspiratory reserve volume is breathing forcefully? Yes, that is a forceful breath after you've done a normal inhalation. So if you just do a normal inhalation, so normal breath in, then you do a massive inhalation after you've already done that. Okay, that is your inspiratory reserve volume. So it's basically how much air can you force into your lungs after you've done a passive breath in. That's what this shows. The inspiratory capacity is basically normal breath and that forced inhalation all in one. Does that make sense? Are there any other questions, guys? Nice. Any other questions? Cool beans. Oh, cool. Already did that. Cool. Whoops. Okay. So what are we talking about here? Where are we? Okay. What we're looking at here is our our minute ventilation rate and looking at our alveolar ventilation rate. Let me just change it to this, and that should still work. Can you guys still hear me? Just double checking, because I've just changed it. I'm sorry, all I'm seeing is the chat is just yes, 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 yes. Awesome, thank you. Oops. Here we go. So, oh hey, I forgot, I've got chat things. So there you go. Can you guys actually, yeah, you can see yourself on the chat. Cool, I forgot I added that. So what we're seeing here with our ventilation rate, what this is describing is essentially the amount of gas, the amount of air that we can move into and out of our lungs per minute. So if we look at this as an example, our ventilation rate is looking at our tidal volume, and we multiply that by how many times you are breathing per minute. So I want you to think of this as almost like cardiac output. Okay, instead of stroke volume, or how much blood is leaving the ventricle per cycle, that is our tidal volume. That is how much air we are breathing per breath. Okay, that's looking here. Okay, our tidal volume. And we multiply that by how many times you breathe per minute. Now, again, these are all average values. But what I want you to sort of keep in mind here is that this ventilation rate is not the same thing as the alveolar ventilation rate. Now, what this describes is that breathing in and that breathing out, but taking into account this dead space. Now, what do I mean by dead space? Well, as I've described to you guys over here, we have this residual volume. We have this bit of air that sits in our lungs, and we can't forcefully breathe that out. What that means is, as we do a nice big deep breath in, do I have a picture of lungs? Uh-oh. Okay, my PowerPoint just froze and I panicked. As we breathe in and the air moves into our, trachea and down in our bronchioles and blah, 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 what that is going to do is that nice, fresh, clean air that we're breathing in is now mixing with the air that is in that residual volume, that dead space. Now, this obviously has an effect on the exchange of oxygen and the exchange of CO2. So as we move oxygen into our blood and CO2 out, as you exhale, that dead space, that residual volume there, will have quite a lot of CO2. So as you breathe in for that second breath, that means that nice clean air is mixing with that dead space. So that does have a slight effect on that ventilation rate. Now, what I want you guys to pay attention to here are some of these values. So if we do normal breathing, normal rate of breathing, normal depth of breathing, okay, tidal volume 500 mil, and let's assume sort of 20 breaths per minute. What that is going to give us is 10,000 milliliters or 10 liters per minute that you are breathing, and an alveolar ventilation rate of 7,000 mils per minute. Okay? And again, this alveolar ventilation rate is a good indicator of how much gas we are exchanging and putting into our blood. Now, what is very interesting, if we look at this minute ventilation rate here, this doesn't change for all three of these values. These are all 10 liters per minute. But what I want you guys to pay attention to is, let's say we're doing this rapid, shallow breathing, like you're in, say, shock, or you're in pain, okay? You're panicking. Everyone always says, calm down, slow down your breathing. Because what is happening here with this rapid and shallow breathing, it's not properly sort of mixing in and clearing out all of this dead space, which means even though we are moving the same amount of air, the effective ventilation is half of what happens if we take nice, slow, deep breaths. So even though we're moving the same amount of air, the actual ventilation rate within the alveoli is very different. So this is why when if you have a patient that's panicking, that is in distress, tell them to slow their breathing, to not panic and sort of pant and breathe in and out rapidly, because that's the last thing that we want. So just a quick reminder, okay, with some of our definitions. So our external respiration. External respiration is the respiration or the exchange of gases between our lungs and our blood, okay, our blood vessels. The internal respiration here, that is the exchange of gases, so oxygen and CO2, between our blood and our tissues. That's where we want to deliver our oxygen to and remove that CO2 from. Now, one last quick thing we'll talk about before we have a bit of a breather, okay, is looking at our air and partial pressure. Because what you'll notice so far, guys, and I've brought it up a couple of times now. This one. Here we go. Sorry. I've mentioned this a few times. I've brought this up a few times, and that is when I've been talking about ventilation. So moving air from here into here, I refer to that as air. Once it's getting into the alveoli, we're talking more about respiration. So we're talking more about movement of specific gases into or out of the body. That's when I'll be more specific. That's when I'll be using oxygen or carbon dioxide. What's important to keep in mind here, guys, is Dalton's law of partial pressure. Now, this law sounds complicated, but it's actually incredibly simple. What Dalton's law says is that the total pressure of a system is comprised of all of the individual pressures added up. Now, right, what does that mean? So, if I do a bit of rewinding rather, I said to you guys all the way back here, right, our normal atmospheric pressure, our normal air pressure is 760 millimeters of mercury. Okay, that's cool. Why? Why is it 760 millimeters of mercury? Why is air doing that? This is where Dalton's law comes into place. So, air is not just one thing. It's comprised of many things. We have nitrogen, which is the predominant molecule that's in the air. We've got oxygen, we've got CO2, we've got methane if you're sitting next to someone who's had a particularly gaseous meal, that sort of thing. There's also a bit of water in there for humidity and stuff like that. Now, it's all of these different things combined together that comprise our pressure. Okay, so for instance, if we have an overall atmospheric pressure of 760 millimeters of mercury, we know that nitrogen comprises 78.6% of our air. So if you do the math on that, like 78.6% of 760 is 597. Okay, so again, what does that mean? What is that telling us? That means that out of the total of 760 millimeters of mercury, 597 of those millimeters of mercury are being generated by nitrogen. So what this means is, if I was to take the air in this room right now, and I activated a magic filter and said, get rid of all the nitrogen, just suck out all the nitrogen, it's gone, get rid of it. My pressure, the air pressure in my room right now would decrease by 597 millimeters of mercury, because that was the amount of pressure that was being generated by nitrogen. Now, what we see here with Dalton's law is a huge effect with altitude and air pressure. So as you move up, like higher up in altitude, the air thins, okay? We have less of these, okay? We have less nitrogens and oxygens and waters and carbon dioxide. And because we have less of these molecules in the air around us, the air pressure, or atmospheric pressure rather, will decrease. It goes down. This is why as you go higher and higher up in altitude, it gets harder to breathe. Why? Because what do we rely upon very, very heavily when we are breathing? That pressure gradient. We are opening up our lungs and expanding them to increase the volume and decrease the pressure inside of our lungs. Why? So that air will move from high pressure to low pressure. That's how we breathe. This becomes a problem in higher altitudes because what we're seeing here is a decrease in our pressure gradient. Instead of being up here, if we go really, really high up in terms of altitude, we might only be here. This means it's harder to get air into our lungs. Oops, let me turn off my pen here. So, composition of inspired air and alveolar is different because of three influences. What am I saying here? What does this mean? It means the air that is surrounding my face, my head, right now, the air that's around here is different fundamentally than the air that is in my lungs right now that I am currently exhaling as I'm talking to you all is different for three main reasons. First of all, the air is humidified. So remember, as I'm breathing in, okay, we've got those nasal meatus and nasal concaves there that are making the air more turbulent. It's coming into contact with the pseudostratified columnar ciliated epithelium lining the nose and the nasopharynx there. And what that is doing is it's humidifying it, okay? This is why when you exhale on, say, a window or something, it will fog up, okay? Secondly, the inhaled air that I'm breathing in, once it hits my alveoli, it is different in terms of composition than the air around me, because we need to remember this residual volume, okay, or this dead space. Because what that is doing is it still has quite a high concentration of CO2 and a low concentration of oxygen. Why? Because it's leftovers from the previous breath in. So it's going to mix in with that. And then what we're seeing is, as I've breathed in, the oxygen is moving into my blood and carbon dioxide is moving out. What that means is if you were comparing the composition of air inside my lungs right now versus the composition of the air in this room right now, what you will see is that it's only 65% of oxygen. Which, again, if we think about it, it makes sense. It checks out. Why? Because we are using it. It's like me saying the amount of food in my house on Monday is not the same as the amount of food I have in my house on Friday. Why is that? I used it. I ate the food. I consumed it. It's the same here with our lungs. You're not going to have the same amount of oxygen outside as you do inside because we're undergoing this external respiration. We're taking it from our lungs, moving it into our blood, and transporting it around our body. Now, in the same way that we see our PO2 is only about 65%, right? The partial pressure of CO2. So when I'm saying partial pressure, I'm talking about this, like the individual pressure that it's generated. That is 130 times higher. It's a huge increase. Why? Well, in the same way, it's like saying, well, Brock, at the beginning of the week, you didn't have any garbage in your house at all. But by Friday, you had 2 garbage bags full of rubbish. What does that mean? It means I generated waste, okay? I ate my food, okay, which is my oxygen, and I threw away the trash, which was my CO2. So the garbage was getting higher. Okay, so what we'll do, guys, we'll have a bit of a breather there. We'll take a quick break because we've slammed through quite a bit of content here. Okay, we'll have sort of a 5-minute break. Again, same rules apply, even though I'm not there to visually see it and enforce it. Stand up, stretch your legs, fill up your drink bottles, make a cup of tea, do what you need to do, and we will come back in about 5 minutes. Alrighty. So guys, before we sort of push on with the rest of the class, how are we finding this so far? Yeah, looking for a little bit of feedback. Is things good? I know there's a few internet dramas, which is unfortunate. Couple of things. One, this is being recorded. I will be putting this on the portal for you guys, and I'm also doing a local recording as well, just in case that does go belly up. So we've got some contingencies, which is good. But yeah, are we enjoying this? Would we prefer to swap to Zoom? I am happy to do so. That means you guys can use your microphones and stuff like that as well. Yeah. Just give me a bit of feedback, guys. How are we feeling? How are we going with it all? I mean, I'm a little bit biased. I think the YouTube thing is not too bad. I think it's working well. It's obviously a little bit harder for you guys to engage in terms of things I'm saying because you have to type. But yeah, cool. All right, let us push on. Let's keep going. Let me move this. Here we go. So I'm gonna go this one. Yeah. So what were we just talking about? So we were essentially looking at the difference in the composition of air versus like what is around me right now versus what is in my lungs. Now, what I want to do is talk a little bit about the biochemistry of that. Now, this is going to get a little bit tricky. Why? Because you guys have never done chemistry before. And these next couple of slides is what I teach my biochem students, which is the equivalent of sort of second year biochemistry in biomedical sciences. So this will get a little bit tricky. However, I'll do my best to explain it for you guys in a manner that is as simple as possible. And I do believe it's important because it's key in terms of understanding how your body transports oxygen and CO2 around the body. Okay. So I'm just going to quickly go to this screen just so I'm not covering up anything. So gases dissolve according to their pp. What do I mean by pp? Not what you're thinking. I mean partial pressure, okay? Okay, I'm talking about partial pressure. So what I mean by partial pressure is what we were looking at here. So, you know, the partial pressure of nitrogen is 597 millimeters of mercury. Okay, that sort of thing. So these gases will dissolve. However, CO2 and O2 by themselves, they're not very soluble in water. And even then, carbon dioxide is like 40 times more soluble than oxygen. Does anyone have a soda stream or know what a soda stream is? Does anyone understand when I'm making that reference? Yeah. Actually, let me see if I can Google it. Let me do this. Soda. Oops, that was the wrong thing. Yeah, here we go. That's a soda stream. Okay, so what you can do is you can basically fill up this bottle with water and you pop it in and you hit the button and it basically carbonates it. So you can put in a canister of CO2 and it basically gives you soft drink, gives you fizzy drink or mineral water, whatever you want. Now, why is it CO2 and not, say, oxygen? Why don't they just put oxygen in there instead of CO2? Because of the solubility, okay? CO2... my Zoom worked well yesterday. This YouTube keeps buffering, but it recovers. Try hitting the little gear cog at the bottom right and see if you can change the quality of it. It might default to 1080, which is why it's having troubles. Try changing it to, say, 720 or 480. See if that helps you. If you are still having troubles, please let me know. And what we'll do is we'll pause this and we'll jump over to Zoom. We'll use it that way. Okay. So, yeah, touch base. Let me know. Anyway, the reason why we use CO2 instead of oxygen is that CO2 is much more soluble. Okay, so it means it can dissolve in water, which is why when you open up a can of soft drink or a bottle of Coke or whatever, it will fizz and it'll start to bubble. That's those CO2 gases leaking out. Now, the big thing here, we are very big multicellular organisms, okay? If you are very small, say like bacteria and stuff like that, like sort of single-celled organisms, you can just rely on diffusion, just basically taking the air out and just moving it straight inside. We are far too big for that. We need a circulatory system. So we need red blood cells and we need, blood and things to transport and traffic them around. Now, how we do that is by this lovely protein called hemoglobin. So, hemoglobin is a protein that is inside of your red blood cells, and what it will do is it will hold on to oxygen, and when it moves around the body, it will deliver it to the tissues, okay? So, when your red blood cells, or your erythrocytes, move into your alveoli, and gas exchange is occurring, your blood is becoming oxygenated. What is happening is that oxygen is moving into your red blood cells and is binding to these hemoglobin molecules. Now, the big thing here, I'm actually going to come back to this slide. Yes. As in, yes, that's working, or yes, you want to swap to Zoom because you're having issues with YouTube. Sorry guys, so pause of game. What I want everyone to do for me right now is I want you to type either 1 or 2 in the live chat there. 1 means you want to stay on YouTube. 2 means you want to swap to Zoom. If you don't have a preference, if you're happy with Zoom or YouTube, just put 1 and 2. Okay. But something I could try and do, might be putting a bit of strain on the system here. Both are okay. Let's try this. Alicia, if you're still having issues, oh, I hope I don't just break everything. Oh dear. Let's do this. Done. Let's just get rid of that. Done. Good. Share screen. Okay. Code. So 702 697 2238. Okay, I'm oh god, now I've got, oh no, that's not there. Okay. I was like, oh no, there's 2 of me. I'm really testing the waters here because I am now streaming twice. So I am actually streaming to YouTube and I am streaming to Zoom. So I'm doing both at the same time. How's my network? Actually, it's not too bad. That's all right. That's not too bad. Let's see how we go. If you want to join via Zoom, that's cool. If you're happy to chill on YouTube, that's also cool. It's just that way if some of you... No. I'm just saying if you are having difficulties with YouTube, if YouTube is not working properly for you, you can use Zoom. I've just given you that as an option for you guys. Sorry, let me do this. Record. Done. Okay, so now that's recording there. Oh, we've got recordings everywhere. We're recording to my local PC. We're recording to YouTube. We're recording to the Zoom cloud. We're everywhere. We're everywhere. I love it. Okay, so hopefully that'll help solve some issues. Let me know, guys. As I said, I'm happy to do some workarounds. We'll figure some stuff out. We'll figure it out. Now, what are we talking about here in terms of our dissolving gases in fluids? This is called Henry's Law. Do I care about Henry's Law? I'm sorry, Henry, but not today, okay? This is absolutely not a priority for me. All I want you to know with this is that the amount of gas that will dissolve in a liquid depends upon its solubility. What this means is it is so much easier to dissolve carbon dioxide in water. We can dissolve way more carbon dioxide in water as opposed to oxygen because of its solubility, which again makes sense. This poses a big problem for us as an organism. Why? A lot of us is water. And trying to transport oxygen around the body is a massive issue. Because as we can see here, the partial pressure gradient for oxygen is really steep. Okay, the alveolar partial pressure of oxygen. So this is the partial pressure or the amount of oxygen I have in my alveoli. It's around 104 millimeters of mercury. Now, the venous blood, so the blood that's moving through my veins, the amount of oxygen, the partial pressure of oxygen in there is 40. Okay, so that's nearly a threefold difference. That's nearly like 3 times the amount of oxygen compared in our lungs compared to our venous circulation. Now, if we can compare that to the partial pressure of, say, carbon dioxide in the veins, when we see, obviously, CO2 being a lot higher, it's 45 millimeters of mercury, whereas in our lungs, it's only 40. Like, it's not that big of a jump. It's like 5 millimeters of mercury, yeah? Whereas this is like, nearly 80 millimeters of mercury versus 5. Huge difference. Why is that? Because CO2 is just way more soluble. We don't need this gigantic pressure gradient. Yeah, we don't need this really steep pressure gradient for CO2. With CO2, we can sort of like have a real shallow, real level one, because it is more soluble than oxygen. That's the big takeaway message here. Here. Let me go back to here. Here we go. Good. So this poses a challenge for us. This makes it a little bit more tricky for us. Now, look, I'm not going to go too much into this. All I want you to see here, and this is another good example of us sort of tying things together. So what we have here is the heart, okay? We have seen our pulmonary circulation, okay? Our right atria, right ventricle, tricuspid valve, moving up into the pulmonary trunk via the pulmonary semilunar valve. Again, I hope we're all remembering this. We're all repeating it. Practice. Okay, then it's heading off to the, our pulmonary arteries, pulmonary arterioles. We are removing CO2 and moving in oxygen. And we can see, okay, the inspired air versus the alveoli in the lungs. Okay, we've still got some CO2 in there. That's from that dead space. Then it's being circulated around the body. And you can see as this blood is moving around the body, look at the change in terms of the concentration of oxygen and CO2. We are consuming oxygen and we are trying to get rid of CO2. And that's what we're seeing here by this internal gas exchange. So this is the internal gas exchange down here. And this is our external gas exchange. Okay. Now, as we move then back to the heart, okay, we are obviously far less oxygenated and the whole process starts again. I'm going to talk about that later. I want to talk now a little bit about cooperative binding. So guys, this is where I'm going to rely on you guys to chat with me, make sure that we're all keeping up, making sure that we all understand, because this is where we're going to be... this is where things are going to get a little bit more tricky. So, I just thought of something. Can I? Yeah, here we go. Here we go. Let me do that. Awesome. There we go. Now, here's the thing, guys, for hemoglobin. If we think about what it's doing, the problem that we have is that we wanted to do the same thing, but in opposites. So it's like me saying, I want you to hold a glass, but never hold a glass. Or I want you to pick up the phone, but don't you dare touch your phone. It's sort of like, hang on, wait, what? I'm giving you complete opposite instructions. It's like me saying to hemoglobin, I want you to bind to oxygen, but let go of oxygen. What does that mean? I want it to, when the blood is reaching the lungs, I want it to scoop up and grab oxygen. But when it's moving around my body, I don't want it to hold on to oxygen. I want it to deliver oxygen. So, for hemoglobin to be an effective transporter, it has to bind when the oxygen PO2 is high and release it when it's low. But the problem that we have here is that if oxygen has a high binding affinity. Now, what do I mean by binding affinity? So affinity, willingness, yeah? The binding affinity is referring to how willing it is to bind and hold on to something. So we want it to have a high binding affinity for oxygen when the concentration is high, because we want it to scoop up and grab those oxygen molecules in the lungs. But we also want it to let go. We want that binding affinity to be lower when the oxygen concentration is low. Why is that? Because, well, when we're in the tissues here, we want it to ditch that oxygen. We want it to get rid of that oxygen and scoop up this carbon dioxide or bicarbonate. So, which one do we want? Do we want a high binding affinity or do we want a low binding affinity? Right? Oh, nice, that works. Because here's the issue. If we say, no, we want a high binding affinity. That's great if we're in the lungs, yeah? A high binding affinity means when it's in the lungs, it's scooping up those oxygen molecules left, right, and center. It's having a great time. The problem is when it gets to the tissues. Because if it has a high binding affinity, when we move to the tissues and it's like, okay, it's time to deliver that, the molecule's not going to want it. Think of it like a courier or like a postal worker. Okay, you know, like your postie, the people who comes around deliver your mail. Let's say we order. This is a good example. Let's say we ordered the new S20 Ultra because we like to spoil ourselves with some new phones. Let's say I ordered that, and that had to be delivered by courier. Do I want that courier to have a high binding affinity for my parcel or a low binding affinity? High binding affinity means he's going to go to the warehouse, he's going to pick it up and make sure that he delivers it. That's a good start. But But let's say then he drives to my house and he's like, hello, Mr. Grant, here is your new phone. And I go, oh, thank you so much. And I go to take the phone. You know, I go to get the parcel and he won't let go of it. He's like, no, this is it. This is your phone. I have this now. This is mine. So that's a problem because he's not being a very good delivery person if he's just holding on to the parcel. He's not delivering it. Now, let's flip that. Let's say he has a low binding affinity. He doesn't really want to pick up the phone. He's happy to get rid of it. He's like, yeah, sure, take it. Here you go. But then it's like, oh, can you please deliver this parcel for me? It's like, I don't really want to. I don't want to grab it. I mean, if I really have to. So then we have the opposite problem. It's easier for him to get rid of the parcel, but he doesn't want to pick up the parcels in the first place. So what we need is both a delivery driver who wants to pick up the parcel and deliver it. And this is what we see here with our cooperative binding. Okay? So with this cooperative binding, our hemoglobin will actually change its shape. So it's going to go from low affinity, which is its T state, to a high affinity, which is its R state. How does it do this? It's done based on oxygen. So for instance, as your hemoglobin molecules are moving to the lungs, as we get more and more, like a higher concentration of oxygen, what we are going to see there is that hemoglobin is going to shift. It's going to change from this T state to an R state. And what we're seeing is that these oxygen molecules here, as one binds to hemoglobin, it will cause it to start to change and change its shape and move, making it easier for a second oxygen molecule. And then that'll cause it to move even more. And then a third oxygen molecule, and then a fourth. Once it has all four, then it is very much in its R state. Now, resulting in oxygen functioning as an allosteric effector. Again, another big complicated word. What does that word mean? It means by a molecule caused it to change its shape. Okay? That's all an allosteric effector is. It is a molecule that causes another molecule to change its shape. And this is important because we want oxygen to do that. So oxygen is an allosteric effector because as oxygen binds to hemoglobin, it causes it to go from this T state, this low binding affinity, cause it to shift and change to its R state or its high binding affinity. What this means, the fact that our hemoglobin molecules can do this, what does this mean? This means we get the best of both worlds. What this means is that when there are heaps of parcels around, when there are heaps and heaps of parcels, like say, I don't know, at a warehouse, then it's going to make our postie have a high affinity. It's going to go, ooh, look at all these parcels, I'ma grab them, let's go do some deliveries. And then as he delivers things around and he moves to our tissues, or like say our, the delivery address, suddenly his binding affinity is going to be lower. And he's going to be like, okay, let's just get rid of the parcel. Let's just get rid of it. Let's deliver it to the proper place. Let's call it a day. Okay, so we're getting the best of both worlds. I hope these analogies are making sense to everyone, my weird postie analogies. Okay. So, here's what I'm referring about with our hemoglobin molecules. Okay, it has 4 oxygens, but then as we move, around the body and we deliver that oxygen, it starts to lose it. Now, something I want to mention now is called the Bohr effect. As I've mentioned here, oxygen is a good allosteric effector. So what that means is that if there's lots of oxygen around, it's going to increase the binding affinity of oxygen to hemoglobin, which means that our blood can scoop up way more oxygen from our lungs. But how do we make our red blood cells deliver that oxygen? How do we make these hemoglobin molecules get rid of those oxygen molecules and deliver it to our tissues? This is where the Bohr effect comes in. Now, we've got some lovely squiggles, we've got some lovely curves here, because one of the biggest factors that controls whether oxygen is delivered to your tissues is pH. Now, what do I mean by pH? I mean how acidic something is. So, when we are breathing, you guys are doing this, well, I hope you're breathing, okay? What you are all doing right now is this, okay? Aerobic respiration. So you are breathing in oxygen, you are creating energy by ATP inside of your cells, and you are producing carbon dioxide as a byproduct. So what is going to happen is, as you create more CO2, and obviously it's surrounded by water, this is then going to be converted into carbonic acid. Okay? And it uses this enzyme, carbonic anhydrase. So I know this is a lot of chemistry, guys, bear with me. Now, what's going to happen is that this hydrogen is going to be released. The definition of an acid is the ability to get rid of these hydrogens. So what this means is the process by creating energy and releasing carbon dioxide, this makes it more acidic. Okay, so surviving generally. So our body using oxygen and making ATP, making energy, is kind of making us more acidic. Okay. What on earth does that have to do with transporting oxygen? Why is that important? Why is that even relevant? Because of this. What this effect, the Bohr effect, is, what this is showing us is that as the acidity goes up, okay, as your tissue gets more acidic, the ability for hemoglobin to hold on to oxygen decreases. What this means is, as the blood moves from our lungs and moves, back into the heart and then will circulate around the body, around our circulatory system, what it's going to be doing is coming in contact with our tissues. Now, your tissues are producing carbon dioxide as a byproduct, and the amount of carbon dioxide it is producing depends on the tissue, depends on how hard it's working. If you're running at a dead sprint, your leg muscles are going to be using a lot of energy. It's going to be using a lot of oxygen, and it's going to be creating a lot of carbon dioxide, as well as creating lactic acid, and it's going to be getting quite acidic. Why is this important? Because as the acidity goes up, as we are getting more acidic, the ability for hemoglobin to hold on to those oxygen molecules, okay, the ability for hemoglobin to hold on to these oxygen molecules plummets. So if we look here, this hemoglobin molecule here is at 100% saturation, so it has 4, whereas this one is only at 75%, okay, it has 3. This one is 50%, 25%, 0%. So if we compare this, so if we look at hemoglobin at, say, a pH of 7.6, okay, at a 7.6, at a, let's say 40, okay? At a partial pressure of 40, a pH of 7.6, it's around 80% saturation, yeah? Give or take. Now, if we make this more acidic, so a pH of 7.2, that's much more acidic. If we compare that, it's only 60% saturated. So the more acidic something is, the less likely your hemoglobins can hold on to those oxygen molecules, and it will then be released and it'll be delivered to those tissues. Now, this is dope. This is really, really, really cool. Why? Because what this essentially allows your body to do is selectively control how much oxygen each of your tissues get depending upon its use case. If you are running like a madman or a mad woman, either, your leg muscles are going to be working like crazy. They're going to be working a lot harder than, say, my biceps. My biceps are probably working too if I'm sort of swinging my arms up, but nowhere near as much as my legs. What this means is, as that blood flow is moving around my body, as it's hitting my legs, it's getting, where was it? it's getting way more acidic because as I'm running like crazy, I'm producing heaps of carbon dioxide. By producing heaps of carbon dioxide, I'm creating a lot of this acid. And that acid is being released, which what that is doing is building up in the tissues, and that's making your tissues more acidic. Which means as the blood flows through to, let's say this is your leg muscles, okay? It's moving through into your leg muscles. Suddenly, whoa, very, very, very acidic. Okay, very acidic. That means hemoglobin is going to get a case of the butterfingers. It can't hold on to those oxygen molecules. So it's going to drop that oxygen. It's going to deliver that oxygen, which is important because if your tissues are getting very acidic, it means it needs oxygen. It's under a very high demand. Now, as I was explaining in week 2 and week 3, how we have different receptors around the body. We have different, mechanoreceptors or chemoreceptors that are detecting different things. Some of our chemoreceptors that we are detecting is looking for changes in pH. And if your body suddenly goes, hey, whoa, we're getting quite acidic here, yeah? We need to start moving oxygen around the body. We need to increase our heart rate. We need to increase our stroke volume, increase that cardiac output, move that blood around the body because we are under stress. We are under strain. We need to deliver more oxygen around our body to ensure that we are okay. Does that make sense, everyone? Because that is particularly complicated. That is quite tricky to get your head around. Is everyone okay there? He says as he has a cup of tea. We're all good, we're all okay? It's all making sense? Are we there? Can everyone hear me? Can everyone see me? Don't freak me out like that, guys. I thought something happened. I thought like the stream crashed or something. Oh my goodness. Yeah, so is that making sense for everyone? Because again, I can try and explain that again if you want. It is a tricky thing to try and get your head around. All right, so what I've just described there is essentially that is the Bohr effect, okay? Kinda. Whereabouts have I lost you, Cindy? Whereabouts have I got you a bit lost or confused? Is it this part? I don't understand the partial pressure of oxygen, the curve graph. Oh, this one here. All this is showing you. So what we have on our y-axis here is looking at the oxygen saturation of hemoglobin. So what do I mean by that? That's what I'm looking at here. Yeah, that's right. It means the O2, yeah. So if I have 100% saturation, that means all of the hemoglobin molecules in my body are all full, okay? If it's down to, say, 80% saturation, it means a lot of them have lost one oxygen molecule, but some of them probably have 4. If we are down to here, 0% saturation, which means, you're dead. What that means is that all your hemoglobins have no oxygen molecules at all. So what this squiggly graph is telling us is that this first graph is looking at the partial pressure of oxygen, so how much oxygen there, concentration, versus how much hemoglobin, like how much oxygen is on the hemoglobin. So if I have a very high partial pressure of oxygen, it means more of my hemoglobin are going to be saturated. They're going to have those oxygen molecules bound to them. Because that's what we want. Because like in our lungs, this is a high saturation of oxygen. Okay, lots of oxygen. Why? I just took a big deep breath in, lots of oxygen here. So I would expect a lot of my hemoglobins to be full at my lungs because I want them to be. I want them to be scooping up those oxygen molecules to deliver around my body. So what is this graph telling us then? What this is telling us is that if we change the pH, so if we, as the number gets lower, it's getting more acidic. So a pH of 1 is incredibly acidic. That's like hydrochloric acid sort of thing. Very, very, very acidic. And the opposite end is 14. So what we're seeing here on this graph is that as we get more acidic, okay, we're getting more of these acids, it's harder for our hemoglobin to hold on to the oxygen molecules. Because if we compare, again, let's say at a partial pressure of 40 or a partial pressure of 60, so let's say partial pressure of 60, okay, at a pH of 7.6, it's around like 90% saturation, which is pretty good. Whereas if we compare it to a pH of 7.2, which is more acidic than 7.6, if we compare it here, it's around 80, okay? Or maybe even less. Yeah, it's around 80-ish%. So what that means is that when it comes to delivering oxygen around the body, as the acidity increases, as we're getting more acidic, it's harder for our hemoglobin to hold on to the oxygen molecules there. And that's useful for us because that's exactly what we want to happen. We want it to be delivered here. Here. So we want it to be delivered here. Oh, good stuff. Good. Is everyone else okay? Is there any other questions? These are good, guys. I like these questions. Keep them coming. All right. So now, sorry, let me just go back to this part. Now, what we have essentially described is this part here. So we've said, okay, there's lots and lots of oxygen here. It's going to move into our red blood cells. The red blood cells are going to move to our cells. Now, these cells are going to get more and more acidic depending on how much they are being used, which means that as it's getting more acidic, more oxygen is being dumped into these tissues. But then there's another big factor here, and that is this carbon dioxide. How do we get rid of it? Because as we've said, in the lungs, we are exchanging carbon dioxide and oxygen. So oxygen is moving into the blood from the lungs, and carbon dioxide is moving out of the blood into the lungs so that we can expire, okay? We can sort of breathe it out. So, how do we do this? We have three main ways. First of all, we can have dissolution directly into the blood. So what that is essentially saying is, and this is sort of what I was saying like all the way back here, is that carbon dioxide is more soluble than oxygen. Oxygen is way less soluble in water. Okay, so a lot of the things like when we're trying to transport oxygen around the body, we can't just say, oh look, dissolve it in the blood, we'll dissolve it in the plasma, and away you go. Doesn't work like that, okay? The solubility is way too low. However, the solubility of carbon dioxide is much higher, okay? It's like 40 times more soluble. So what that means is we can get away with kind of turning our body into a soda stream. Yeah, and just putting carbon dioxide straight into the blood and transporting it that way. The second way is we can bind to a hemoglobin molecule. So what this means is that in the same way that like with our hemoglobin molecule here, that we bind these oxygens, as our hemoglobin starts to get less and less because it's delivering those oxygens, what we can see is that a CO2 molecule will very cheekily, it will just sneak itself in and bind to one of these sites here. So that's the second way, is just to have hemoglobin and a CO2 molecule will just bind together like that. The third way, and this is the most common way, is it's carried as bicarbonate. So what does that mean? So, as I explained to you guys before, when our cells are doing work, okay, they're producing ATP, so adenosine triphosphate, they're taking our sugar and our oxygen and they're making it into energy. This is how we survive. This is how you're literally existing right now. If your body stops doing this, you're toast, you're dead. Like, no ifs, no buts. So, your body is then creating carbon dioxide as a byproduct, and it's converting it into carbonic acid. This hydrogen is leaving, which is what is making it more acidic. That is what's doing this, okay? That is what makes your tissue more acidic. That is what allows us to deliver more of these hemoglobin molecules. So that's what this one did, but we still have this bad boy left over. Yeah, it's still here. So what we do is we can take this bicarbonate molecule and move it into a red blood cell. And then that red blood cell will move to the lungs. And then we will convert it back into carbon dioxide and we breathe it out. Okay? And that's what we see here. So oxygen is being delivered, and then this carbon dioxide is turning into this bicarbonate. Okay, so we saw that here. Okay, that is our bicarbonate. This bicarbonate is moving into our red blood cell, transporting around right atria, right ventricle, blah, 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 going all the way to the lungs. From there, it then is converted into carbon dioxide, which is a gas, and we breathe it back out. Ooh, excuse me. Choked on my own spit. Now, do I expect you to know and understand how it is that it converts it from carbon dioxide back into from bicarbonate back into carbon dioxide? Absolutely not. Not interested. All I want you to know is that our body can transport carbon dioxide in three main ways. The first one, it will dissolve carbon dioxide straight into the blood. The second way is that it will bind it to hemoglobin, okay? And it will move around. So it's like me basically taking my S20 box that's empty, or got my old phone in it at the moment, and giving it to the postie and saying, hey, can you throw this in the bin on your way out for me, pretty please? That's pretty much what's happening here. And the third one is basically this bicarbonate ion. It moves inside of our red blood cell and it's transported to the lungs. Does that make sense, everyone? So question, so hemoglobin carry both CO2 and O2. Yeah, that's correct. That's exactly correct. Just keep in mind that this third option, how it's carried as a bicarbonate ion, that is the most common. Okay, that one is by far the most common. But to sort of help out, yes, our hemoglobin molecules can bind to that CO2 and transport it away. That's what this lovely chemical structure is. Again, I don't expect you to know this chemical structure at all. Don't even worry about it. This slide I pretty much just copied straight from my biochemistry slides. Awesome. That's fantastic, guys. I love it. Great, great, great. All right, let's have another quick 5-minute break because, again, this is a really content-heavy section of the course and a very heavy content section of these slides. And again, keeping in mind, this will be on your mid-trimester exam, okay? So let's take 5, guys. Stand up, stretch your legs, grab another cup of tea, do what you need to do so that we are nice and refreshed and engaged and ready to finish off this lecture. In the meantime, while we do have this 5-minute break, I do want you to do 2 things for me. One, write down any questions you do have. If there's anything that we've discussed thus far that you are struggling with, please let me know. And secondly, just start thinking about any feedback. Start thinking about, is there anything that you like or do not like with this? All right, guys, let's take 5. Alrighty. So we're all here, we're all back. Let us resume. Where are we? Here, there. Sorry, I'm just quickly double. Aha, okay, it is that one. Wait, no, I don't want that. I want. Yeah. There we go. So I broke something. Oh, dear me. That's why. Gotcha. This should work. But that's fine. That's fine. That's fine. Okay, so now we've finished looking at carbon dioxide transport and how that moves around. I want to talk now briefly about ventilation perfusion coupling. What does this mean? What is this explaining? The biggest thing that you need to take away from ventilation perfusion coupling is it is a positive correlation or a positive relationship. As one goes up, the other one goes up. Now, what do I mean by this? So with ventilation perfusion coupling, what that is describing, and I've said a lot of this in previous classes, it's like with our capillary network, you are not using all of your capillaries all at the same time. Oh, whoops, sorry, just got a question. Oh, don't apologize. I mean, if your internet is suffering, there's nothing you can do. So the question was, will our attendance count the same as prior semesters in person? Do we need to have above 80%? I need to get a hold of my internet provider. Guys, look, I mean, hang on. Let me do this. This is it's tough, guys. This is a tough time. This is a tough situation. A lot of us we're having to work on the fly here. Basically, we're having to work on the fly. We are having to improvise. We're having to work with what we've got. You're not just sitting around on the lounge watching Netflix. You are actively trying to engage with the lesson. So I have already marked you here. That's fine. This is also another reason why I'm recording the lesson in situations like this where, you are just having real internet troubles, okay? I'm recording this 3 different times. I've got Zoom recording it now. I've got YouTube that's doing the live stream that's recording it. And I'm also recording locally to my hard drive. So I've got 3 separate copies. I've got 3 backups, which is good. There's only so much that you can do, okay? The fact that I've seen you here and you've tried to engage, that's good for me. I'm happy to mark you as here. The biggest thing that we have to do, the reason why we have to keep marking attendance, to my understanding, is it's primarily due to visas for international students. We need to report to the government to basically say, look, this student is still attending class, they are engaging in these activities, and it's not like, oh yeah, this person said they're studying, but they're spending all day at the beach or something like that. Okay, we still need to report on these things. So that's why we have to still do that. But obviously we understand that it's tricky. All we can ask is get in touch with your ISP, your internet service provider, and do the best you can. That's all we can ask for. Is there any other questions just in regards to anything and everything? Cindy with the mad flex there. I love it. No, we're all good. Excellent. Yeah, just keep doing your best, guys. As I said, I'm going to try and, adapt the delivery of this course as much as I can to help you guys out, to make sure that you guys are learning the best way that you can. And there's a lot of challenges going on here. There are a lot of people that are very scared. A lot of people are very frightened. A lot of people don't understand what's going on. I mean, look at me right now. I mean, this is the first time I've lectured in the comfort from my own home, and I mean, I could get used to this. This is nice. This is refreshing. I enjoy this. But yeah, we have to adapt to this, and a lot of you, this isn't going to influence, because I think I'm the only one who's teaching you. But be kind to your other teachers. A lot of them just aren't very tech savvy, and they are having to learn a whole lot of stuff very quickly. So, and that is why, again, I'm just really stressing to you guys to just give me feedback. Let me know what are some things that you like, what are some things that you don't like. Are you having issues with a particular platform, and is there ways in which I can improve or change things around? So, all right. On that note, let me do this. Okay. So, as I was saying before, when we were looking at our capillaries, okay, your capillaries are not filled. They're all at the same time, okay. You will have some capillaries that will be opened, okay. Those thoroughfare channels will be opened, and blood will be moving through those capillary beds. A lot of them will be shut. A lot of them will be closed. Why? There's no demand, okay? You don't need to be moving 100% of your blood 100% of the time. That is just an unnecessary use of energy and other resources. The exact same thing happens in your lungs, okay? You do not have all of these bronchioles open all of the time, okay, to really get as much air in as possible. Why? There's no need. So this is where we see ventilation perfusion coupling. So just let me, here we go. So when we change one factor, whether it like blood flow, what we see is the same change with airflow and vice versa. So what we see, let's say looking at this one, if we have our decreased airflow and we see less oxygen within the blood vessels, what is then going to happen is that these pulmonary vessels here are going to vasoconstrict. And what that is going to do, it is then essentially going to decrease the amount of blood flow. If you're not breathing in as much air, let me do this. If you're not breathing in as much air, there's no point in sending even more blood to the lungs. There's no point to that, because again, it's like saying, I have 3 parcels that I need to deliver. I need to hire 30 couriers. There's no need. We don't have the demand. So if we are not needing to breathe as much, like again, you guys all right now, you guys are all just sitting down at home enjoying this wonderful and engaging class. But it's not a physical demand. So what is happening is you don't have this massive demand for oxygen in your body right now. So you're going to be breathing less. Okay, your breathing will be lowered, which means that you're not going to have a huge amount of blood going to those alveolar sacs in your lungs right now. But if you say suddenly looked up and you go, oh my God, the house is on fire, and you run, then let's say suddenly you go, oh my God, run. Okay, huge. Okay, increasing that airflow, increasing the amount of oxygen because you're panicking. Oh my God. What that is going to do is then vasodilate these pulmonary arterioles, and it's going to increase the amount of blood that is moving through these alveolar sacs due to this massive increase in bronchodilation. So again, just to really hit home, as one goes up, so does the other one. Okay, if we see a bronchodilation, so if we bronchodilate, we're getting more air into our lungs. What we are going to see is vasodilation. We're going to be increasing the amount of blood flow to our lungs. And vice versa, if we bronchoconstrict, because we don't need to be breathing in as much, then what we're going to see is vasoconstricting, okay? And that is what this diagram is showing you, okay? That the blood flow matches the airflow, or the airflow matches the blood flow, okay? They will not be out of balance, okay? They always match up. Okay, so again, our favorite area of the brain, okay, looking at our medulla oblongata and looking at the pons of our brainstem, what this is doing is that this helps us control our breathing, okay? It determines the rhythm and the depth of breathing. So, couple of things here. I'm not going to talk about that too much. This is the slide I want. So what we see here is that we have a lot of these like various receptors around the body. You know, we've got these chemoreceptors, like we've got our peripheral chemoreceptors in the aortic arch and the carotid artery. We've got our central chemoreceptors, we've got, you know, found around the body. We've got receptors in our muscles, all of this. And that is constantly signaling to our brainstem information about our lungs and our breathing. So what do I mean by that? So looking here, let's start over here with like our peripheral and central chemoreceptors. So if suddenly we started doing a lot of exercise, we started to really burn through a lot of oxygen, and we start seeing, you know, a lot of oxygen being used, a lot of CO2 being produced, and with that CO2 being produced, we're producing a lot of acid. Okay, so we're getting more acidic. What is going to happen? Sorry, I'm jumping around a whole lot. What is going to happen is that we are going to get more acidic. Okay, we're getting more acidic. We are producing more carbon dioxide, and your body is going to detect that and go, hey, whoa, what are we doing? Hey, you suddenly running? Holy crap, okay, we better start breathing more, okay? We need to get more oxygen in because you are burning through a lot of that oxygen and you're getting more acidic and you're producing more CO2. I need to breathe more. Same with these central chemoreceptors, more CO2, more acid. Holy crap, okay, let's breathe more. And what these are going to do is it's going to, you can see this positive symbol here, say more breathing, increase respiration. And that's why, like, when you start jogging, you can just breathe normally. And then suddenly you'll be like, okay, let's increase that rate of breathing. Because it's basically these receptors giving your brain a poke saying, hey, we need more oxygen. Let's keep it going. Receptors in your muscles and joints. Again, if I start running or if I start doing more physical movement, my muscles are going to activate, which is going to essentially say, hey, I'm doing stuff. Let's breathe more. Now, these are all sending signals, and this can be a positive, like it can cause a stimulus, so say, hey, breathe more, or it can be inhibitory. It can say, don't breathe as much, or stop breathing. So a good example of that is, say, our stretch receptors. So what do I mean by that? So if I turn around and do a big, deep breath in, do I have an urge to breathe in? No. Why? Because my lungs are saying, I'm full. I can't get any more air in. Don't tell me, hey, you should try breathing in. Because if you try to breathe in, it's not going to work. My lungs are full. So the stretch receptors in your lungs will actually inhibit. It'll turn off this signal. Okay? Because it'll basically send a signal to your brain saying, we're tapped out, we're full. We cannot expand my lungs any further. Don't even bother sending me a signal to try and breathe even more because I can't. The other one I want to talk about, which I know we all have felt this, especially if you have a really bad like chest infection, is your irritant receptors. So again, if you've got a chest infection, you've got a really bad cold, a cough, this sort of thing, you're not going to turn around and go, oh man, my chest was really thick and mucusy and bleh. I know what I'm going to do. No, because you'll explode in a massive coughing fit and your lungs are full of mucus and it'll be horrible. So what this will do is it'll basically send signals to your brain saying like, hey, look, we still need to breathe. I mean, I'd recommend it. Breathing's important. But let's not just take massive, huge, deep breaths in and have like huge rates of ventilation there. Because you've got a chest infection, okay? You don't want to have huge amounts moving through. And of course, one last one is a lot of other emotional stimulus, okay? If you're in shock, if you're angry, if you're scared, if you're in pain, this will change your rate of respiration, okay? Plus, higher brain centers. We have voluntary control over breathing, over respiration, I've been doing it this entire lecture going, I can forcibly control my lungs to say, nah, man, we're breathing heavy today. I want to breathe more, okay? So we can override some of these to a point. Okay, it's like me saying I want to hold my breath. Sure, I can hold my breath and inhibit this and say, stop breathing right now. Sure, I can do that to a point where these receptors here start to go, this is getting too much, and basically I'll just, oh God, I need to breathe. Or I'll pass out due to a lack of oxygen, in which case my body will no longer be responding to the effects of the higher brain centers, which means I'll breathe normally. Again, some other factors that influence respiratory activity, so voluntary influence, as I've just said, emotional factors, exercise, okay, if you're running around and stuff like that. Negative feedback. So increase in arterial CO2 or decreasing that can lead to stimulate these chemoreceptors and cause you to breathe more. Additionally, if you drop your arterial CO2, that will actually reduce the urge for you to breathe. So a lot of people don't actually get this the wrong way around. A lot of people think, I feel out of breath. I don't have enough oxygen. The stimulus for you to breathe actually comes from CO2. Because if we look back here at this graph, okay, a lot of these are CO2 and hydrogen. CO2 and hydrogen. That's the main stimulus. So this is why if you, a lot of the Navy SEALs and divers, they are very good at holding their breath. And what you find they do before they need to do a big dive is they will do a large number of really deep breaths to get a heap of that CO2 out and as much oxygen in before taking a big dive. Basically we can change this based on metabolic needs. So as I was saying, if you're turning around going for a run or you're exercising, your rate of respiration will change. All right, we did it, guys. We survived. That is our week 5 lecture. So let me go all the way back. Here we go. All the way back to the beginning. What did we do today? We looked at 3 main gas laws. However, we focused predominantly on 2 of them. Okay? We focused on Dalton's law of partial pressure. So saying that each pressure exerted by a gas, we add them up, we get the total pressure of our system. And the second one was Boyle's law, okay? If we increase the volume, we decrease the pressure. Or if we decrease the volume, we increase the pressure. We looked at all our different lung volumes and our capacities, okay? We looked at how much we can breathe in, how much we can breathe out, and the different compartments there. We looked briefly at the composition of air at the alveolar level. I'm not going to ask you guys to memorize specifically, specific levels, but I would expect you to know that, there is obviously a large jump with oxygen. As big a jump with CO2, but obviously, there is more oxygen in the alveoli than there is in the blood, and there's more CO2 in the blood moving out. That's understand the direction in which those 2 gases are moving. to know the movement of oxygen and CO2 throughout the body. Okay, so looking at our hemoglobin, looking at those binding affinities, looking at what promotes what promotes hemoglobin to deliver oxygen. Okay, it's carbon dioxide and pH, the acidity, and what promotes hemoglobin to scoop up and get more oxygen. What does that? Oxygen. Okay, the more oxygen there is, the more easily hemoglobin will want to scoop up and bind those oxygens. Understand ventilation, like VQ coupling, ventilation perfusion coupling. As one goes up, the other one will go up. As one goes down, the other one will go down. Okay, supply and demand sort of thing. And of course, understand some of the factors that go into controlling our breathing. And that is, looking at our chemoreceptors and looking at our stretch receptors in the lungs and just voluntary control that we can control, breathing in, breathing out. All right, guys, so we will leave it there for today. I will try and put a link to this class online as soon as I can. Obviously, it's going to take some time to do that. Now, tomorrow we are going to do our tute workshop for this. What I want you guys to do for homework, which in essence is basically what I'm going to ask you to do. Okay, so I want you guys. Sorry, Cindy, I just saw your remote. Know Boyle's Law, okay? We're going to have a chat about Boyle's Law. I want you guys to describe for me, so make sure you have a microphone set up because I'm going to ask you to do it, like the step-by-step process of forced inspiration and forced expiration. I am going to talk to you guys about our lung volume and our lung capacities. What is happening here? What does this mean? What is this graph? What does it mean? What are the 3 ways we can transport CO2? What is VQ coupling? And how do we control breathing? Those are the main points that I would like you to focus on. Are there any other questions, guys? Any other questions, queries, issues, concerns? Anything you would like me to cover or go through or discuss? Alrighty. Can you explain peripheral chemoreceptors again? Certainly. Where were we? Whoops. Peripheral chemoreceptors. So basically what that is just looking at the chemoreceptors that are, say, just off the aorta or heading up the carotid arteries, up to your brain. And all that is doing is just basically saying, what's the pH of our blood? How much CO2 is in the blood? How much oxygen is in the blood? Because if suddenly your brain is starting to go, hey, I'm running low on oxygen, that's when these receptors will start to fire and go, hey, do something about this. Let's breathe some more. And we'll send those signals to breathe more. Basically, the peripheral chemoreceptors and central chemoreceptors, the big difference there is just location. And our peripheral chemoreceptors also measure oxygen because that's basically at the very beginning of our systemic circulation. Does that help? Does that make sense? Lovely, wonderful. Are there any other questions, guys? Oh dear. All right, well, again, guys, thank you all very much for joining me today. I hope you found this useful. Again, I would love to hear any feedback that you have, any way that I could improve or refine upon these online classes. I'll have the video up very soon, hopefully within an hour, because I think that's how long YouTube sort of takes to sort out its stuff. have a read through the stuff again, guys. Practice it because we're going to do it in our Tute workshop. Stay safe, stay healthy, everyone. Have a lovely day.